Quiver Full Ministry welcomes you to Fertility Conference 2022. Ladies and gentlemen, Dr. Emeka Ikenna. Dr. Emeka Ikenna is the amiable and friendly lead clinician at the Olive Branch Clinic. He's also the person responsible and possesses a background with extensive experience in focused advanced fertility management spanning over a decade. His areas of core clinical interest include assisted reproductive technologies, very individualized treatment, stimulation protocols, polycystic ovarian syndrome, and its effects on fertility. Dr. Emeka places a special emphasis on the patient-centric reproductive care, and his key professional goal is to provide skilled, comprehensive, and compassionate care always. He's a member of the American Society for Reproductive Medicine, the European Society of Human Reproduction and Embryology, and a regular seat member of the Nigerian Association for Fertility and Reproductive Health, with whom the Olive Branch Clinic is closely affiliated to. Ladies and gentlemen, please welcome to the Fertility Conference 2022, Dr. Emeka Ikenna.
Hello everyone. My name is Ikenna Emeka. I'm the person responsible at the Olive Branch Clinic, Lekki. And today I have been specifically asked to talk about IVF ICSI. For this, I must thank the organizers of this event, the Quiver Full Ministry, for this opportunity. I'm hopeful that our discussions today will be helpful and impactful for those who are having difficulty or experiencing delays. Now, IVF is a technique, in vitro fertilization. ICSI is also a technique, intracytoplasmic sperm injection. These are powerful tools, and their primary objective is to overcome infertility. Infertility is therefore defined as the inability to achieve conception despite regular unprotected intercourse in consenting adults, a couple, spanning over at least a year. For couples who are challenged, we've been able to break down the causative unit. So 40% of the times we find the reason for the difficulties coming from the man. In another 40% of the times it's found to be coming from the woman. In 10% of cases we'll find that the issues are for both sides, man and woman. And in another 10% we find no specific cause for the difficulty. Infertility is impacting a growing number of Nigerian couples of reproductive age. So it is very likely that most of us will know someone who is challenged by this, or most of us or some of us would be indeed challenged ourselves. IVF ICSI is frequently considered as the mainstay of reproductive medicine in terms of trying to target and assist with infertility, and it's usually used when other forms are unsuccessful or are clinically inappropriate. We estimate that at least 4 million live births around the world are as a result of conceptions from IVF ICSI, and that this technology is largely being more and more accepted in societies across the board, including Nigeria. We are aware, for those in the clinical sphere, medical sphere, the 2010 Nobel Prize for Medicine was awarded to Dr. Robert Jeffrey Edward, who was one of the developers of IVF. And this singular honor award does reflect the growing acceptance. It is therefore difficult to deny the benefits of this technology. Now, all I have said so far is pretty academic, pretty technical, and it is of very little use to couples who are challenged. The couple who is challenged in real life is relatively uninformed. They are pressured. They are contemplating a challenge that may appear insurmountable. They are looking at treatment modalities or treatment options that are very expensive and whose success rates are not so very high. So this kind of couple, these individuals should be handled carefully. Why do I say they are relatively uninformed? It's because most societies across the world, most cultures, especially in Nigeria, don't give us any information as we're starting out as young adults, adolescents. Nobody tells us how to have sex. Quite a lot of times we're thrust into this adulthood with preformed beliefs, maybe information from pornography, and so something that is so important to a couple, we're relatively uninformed. Now, we must bear in mind that every couple is different, so approaching them to manage or offer treatment, we must bear in mind the differences. Yes, the objective is the same. We want to achieve a pregnancy in the shortest possible time safely, but the approach to this may vary from couple to couple. Why do I say couples are different? Their ages, the amount of time they spend trying to achieve pregnancy, their level of awareness, education, their disposition to help. Some people are angry, already upset, depressed, suspicious, if they have children at all or they don't have children at all. The cause of the contributing factor. These are the things that vary one couple, from the other. Other additional lifestyle situations, smoking, drinking, obesity, these things are important in identifying and classifying the couple. So, in offering IVF or any mode of conception assistance, caregivers must bear all these peculiarities in mind and offer direct, individualized treatment. So our conception objective is met while catering to the common challenges. So couples in situations where they're having difficulty, how do they approach this issue? We strongly advise they should be objective, they should be in agreement with each other, honest to each other, that's the members of the family unit. They must be timely in seeking for help. The age of the woman is critical. Women are born with their eggs, so the older a woman gets, the more difficult it is for her to achieve conception. Women are born with a fixed amount of eggs, and once she gets to puberty, she starts using those eggs automatically, cyclically, every month. So as she's getting older, two things are happening. One, the eggs are getting lesser in number, and two, they're becoming less and less efficacious. They should inform themselves appropriately. Everything that is being offered to them, they should bear in mind. Try to inform themselves and be conscious of what is being done to them. Now, how should the clinicians or the caregivers handle the couples? The usual flowchart for clinical management is known. First of all, take a good, concise history. They do investigations to try and ascertain the cause. They make a diagnosis before offering treatment. Management must not be unduly sluggish. We typically will not use more than one cycle, the woman's menstrual cycle, to investigate. By the next cycle, you should be offering some form of help, especially in couples who are a bit more mature. Management must cater to the psychology of the situation. Couples in this situation are challenged, psychologically pressures. Our society is a bit unrelenting and unforgiving for couples who are having difficulty, and so this must be borne in mind. Caregivers, clinicians, embryologists must be clear to the couple throughout that the live birth rate is the gold standard for evidence-based fertility management. What is the IVF process itself? Let's go straight to that. First of all, we'll do IVF, we'll do pre-treatment assessment, a pre-treatment assessment. Like I mentioned earlier, we have to be very individualized about treatment. So, for the females, we'll check the ovarian reserve, we'll check prolactin levels, we'll check thyroid function, do an infection screen, do an ultrasound scan to check for ovarian accessibility, uterine structure, all of that. For the men, we'll do an infection screen, typically do a seminal fluid analysis, SFA. All of this information will be used to make a clear diagnosis. Once we make a clear diagnosis, we then offer treatment. There are specific clinical conditions that will benefit best from IVF. These are the following. One, where there's confirmed bilateral tubal blockage. There's severe enough male factor infertility. This is very low sperm count. There has been failed initial treatment. The lesser or the less invasive forms of IVF or fertility assistance have been offered and been unsuccessful. Clomiphene citrate, a couple of cycles of that, IUIs, controlled ovarian hyperstimulation, timed intercourse. If all that has been unsuccessful, then it may be time to escalate to IVF. Where there's a need for donor eggs, where there is a need for genetic analysis or family balancing, gender balancing, all of these situations, we will have to offer IVF. What is the first step? Once we've identified those who will go through the process, we will do typically ovarian stimulation phase. Naturally, a woman will ovulate out one egg a month. For the purposes of treatment, we want to collect more than one egg. So typically, we'll jump into the cycle day 2. We will stimulate her with compounds, which are bodies usually, which are natural to the body, for follicle stimulating hormone to be precise. So it's a hormone released by the body in the early phase of the cycle to get the ovary to release one egg. So we'll give her a higher dose of that. This dose is calculated, however, titrated, bearing in mind her age, her ovarian reserve, the situation with her ovaries, antral follicle count. So we can individualize the stimulation to be optimal. The objective is to collect between 10-15 eggs, not more and not less, to give us our best chance at success. So the stimulation is daily. These are subcutaneous injections. There are a couple of brands that are useful, and we'll typically stimulate for 10 to 12 days. 10 to 12 days. We'll be doing scans serially to check for response, so we can titrate the dose of the injections as the lady responds. The stimulation protocol of choice now is the antagonist protocol. So at some point, I will introduce an antagonist to prevent spontaneous ovulation. This is cetrotide, cetrorelix, and so you take a couple of subcutaneous injections. Now, when the scans suggest to us that ovulation is imminent, the follicles look really large, we will plan the oocyte retrieval or ovum pickup or egg recovery. This is usually timed to be 34 to 36 hours after the very last injection, which we call the trigger. The day of the egg collection is called day 0. So the eggs are retrieved. That same day, the husband's sperm is also collected, prepared, washed, and each of the eggs retrieved after stripping is injected with one of the husband's sperm. If the husband's sperm is not available, probably would have had his sperm frozen previously. That will be thawed out, or if it's been shipped in. So day 0, all the eggs are injected. Why I say injected? Because typically now we do ICSI routinely. The classical IVF will have involved just putting the sperms close to the eggs and watching for them to do what they need to do. But we typically now would inject almost every situation. And we'll check for fertility the next day. So the day of the egg retrieval is day 0. And we'll culture for the next couple of days. And sometimes by day 3 after that, we can do an embryo transfer. But usually nowadays we'll wait till day 5. So we do a blastocyst transfer. The blastocyst transfer is not painful. We don't put the patient to sleep in this case. We, under ultrasound guidance, take 2 or 3 after discussion with the couple. The points during the discussion that we'll bear in mind with things like the situation with the uterus, the endometrium, the quality and grade of the blastocyst, their family situation, what has happened before, and this will inform how many to transfer. Typically, you can transfer between 1 and 2, in some rare occasions 3, to maximize the chance of successful conception. So, this is done under ultrasound guidance. Then we'll put them on what we call luteal support. Because of the processes to retrieve the eggs were a bit hyperphysiological, we found that we need to supplement progesterone after the transfer. So we typically will start this around this time and monitor the levels of this as the patients wait for the pregnancy test, which is between 12 and 14 days after. So this is just a synopsis of the entire IVF process itself. Objective is to retrieve the eggs, fertilize the eggs outside, then safely transfer them after fertilization into the womb and wait for pregnancy. So what we've done is to bypass anything like blocked tubes, severe or low sperm count, and give the couple an opportunity for implantation. Now, in the natural domain, the chance of implantation is 23%, where everything is in place. So with the assisted conception, the fact that we are certain we've gotten the blastocyst inside the cavity and we've put more than one, it's pretty significant an improvement in the success chance. But again, the success chance is individualized. It's individualized. So the pregnancy test is done between 12 and 14 days after the blastocyst transfer, and we would know the result. Now, there's some adjuncts to IVF that quite a number of clinics offer now. I just say a few words about that. things like embryo glue, intralipids, quite a lot of adjuncts are there. There's limited evidence for them to be offered as standard treatment, but they are good, optional. It should be directed by the clinicians, but they should also inform the patients, the couples, of that limited evidence. And the thinking, in quite a lot of scenarios, is that it doesn't harm them, so why not? So I just will advocate that everybody should be fully informed about the potential of influencing outcome. So finally, we come to outcomes. After the entire IVF process, in some cases, we are unsuccessful. This is very disappointing for the couples. The emotional impact is overwhelming. What with the heightened expectation of the process, the invasiveness, the injections, the scans, the expense, the patients are profoundly sad when we're unsuccessful. And there is a potential for depression and pressure on the relationship. So caregivers must realize this, and throughout the entire IVF process, be sharing evidence-based information so they have a realistic awareness of their chances of success. A realistic awareness of their chances of success. This helps to prepare them if for any reason they are unsuccessful. When we are unsuccessful, a treatment audit must be carried out. We have to go back, look at everything, make sure we did it right, nothing was dropped. A post-treatment meeting must be held with the couple. It's very common for couples to feel left alone after it's been unsuccessful, uncelebrated. And as I said, because it's this profound potential for depression, it's critical that caregivers offer help at this time. Counseling, hand-holding, very, very helpful. Options for way forward will be discussed after the audit, and if there's a need for escalation or a repeat, the couple should be counseled towards. Important thing: communication must be kept up during this process. Frequent calls and possible suggestions of visits. Couples handle this differently, but the caregivers must make sure they do their own bit. And when it is successful, now, this is the preferred outcome for all involved, the couples especially. It's a time to give glory to God. It's a joyful time. It's a joyful time, I must say. It is also a further opportunity for the science of fertility management to be propagated. Aside from the couple thanking God and giving thanks and being really happy, they should also use the opportunity to motivate others, giving them information, how the process worked for them. I think I must mention this. The testimony should be given, but specific mention of the treatment protocols should also be shared. This helps motivate other couples coming behind. Word of mouth is a powerful tool in propagation of information, and there's no better time when the process has worked for you. When it's successful, also, the patients are a bit confused. What next? What do we do? They're afraid. Someone want to sit down. Doctor, can I even lie down? So there are many questions. And so caregivers, clinicians must share clear-cut information on what to do way forward. Expectations, the challenges of early pregnancy, especially for those who have never been pregnant. This information must be shared to guide them through the first weeks immediately after a positive pregnancy test up until possibly 12 weeks when the nuchal translucency scan is done and the conventional antenatal can be started. So in summary, IVF is a very, very powerful tool in the management of infertility, but it must be deployed objectively with a positive and safe patient outcome uppermost in the minds of the clinicians and caregivers throughout. So I shall stop here. I'm still available for questions once all the other presenters have spoken. Thank you very much.
So the question is for someone who's done IVF and failed, and is asking. He said, "I've had two IVF I've had two failed IVFs, all in 6 circles recently. It's overwhelming. What advice can you give me?" That's number one. Number two, my question is, how does high blood pressure affects conception? Those two questions first, sir.
All right, good afternoon, everybody. I hope you can all hear me.
Yes, we can. We can hear you, sir.
Okay.
Yes, we can.
Well, thank you again for the opportunity. I'll first of all tackle the question with the couple who've had two failed IVF attempts. It is very disappointing when any form of fertility assistance is unsuccessful. It is very, very disappointing. And if you recall from my talk, I did say usually when we have unsuccessful situations, we do a comprehensive audit. So for this, it will be wise to have that done, to look back, make sure all, the T's were crossed and the I's were dotted, everything was done. Successful implantation at the end of an IVF cycle is sadly not something that is 100%. So we're bound to have some situations like this. Amongst the things we'll advise, sometimes if we have reassessed and we still feel the patient will benefit from that process, they might need to reattempt. Conception is not something that is automatic when you require it. Even in the natural domain, when you're having intercourse at home, you can't be certain which month you will achieve pregnancy. What you do is you persist at it. And so even when we're having assisted conception, we may need to persist. As long as there is a chance from the process and the flow chart for deciding to offer that process correctly picks that process as the option, sometimes we may need to persist. We may also, as I said earlier, be very conscious of the psychological pressures at this time. It's not easy. Repeating IVF cycles is not as easy as having intercourse every month. And so all these things will be borne in mind when we're counseling. So my direct answer is this: if we've had 2 cycles failed, we would reassess, possibly make sure if indeed this is the correct option. If there are any things picked up from the reassessment, this will inform the clinicians on which direction to go. And also counseling will be very critical. Now, as regards high blood pressure and pregnancy, conception and pregnancy are 2 different things. Once you're pregnant, you will shift care to an obstetrician who has ample experience in taking care of women. The entire antenatal service is preemptive. And one of the things we want to watch is blood pressure, because blood pressure in pregnancy can cause quite a lot of damage to the growing baby and also to the mother. So full antenatal service will pick this up. There's medication that can be used to bring the blood pressure down safely. There's monitoring that has to be done to ensure that the possible complications of blood pressure in pregnancy are not met, preeclampsia, eclampsia, all of that. Essentially, it's just to attend a good antenatal service during that, and pregnancy can be managed. It's not a contraindication to getting pregnant, but we have to be conscious while we are pregnant about the potential challenges that high blood pressure would cause, and it can be adequately managed. I think that's what I have to say about that.
Thank you so much, sir. There's one more question for you. Actually, I think there are a few more questions for you, but this particular one is asking treatment for endometriosis for someone TTC after a failed IVF. Next line of action. So I'm not sure if you understand the question. I don't really understand it, but maybe you do, sir. Treatment for endometriosis for someone TTC after a failed IVF. What's the next line of action?
Okay, well, like I said earlier, in the pre-assessment before treatment, I'm sure this would have been picked out, either from the history of recurrent, very painful periods, or she probably had a laparoscopy done that diagnosed the endometriosis. Now, the good thing about IVF is that we're bypassing a whole large chunk of the natural conceptive process. And so we're not making use of the tubes, we're fertilizing the eggs outside, and we're transferring them back into the uterus. I know there are some immunological challenges that come with endometriosis that influence successful pregnancy. So all of this is borne in mind. Now, sadly, with, pre-existing gynecological issues, it does make the success rate a little bit less successful. But it's the clinician's job to appreciate what extent this would be and put in measures to try and work against this. For example, we could decide to downregulate in this case. This is stop the periods for a couple of months to calm down the pelvis before you start another IVF cycle. For example, you could be more focused on the immunology of the process, use things to work against that prednisolone, low-dose aspirin, stuff like that. So there's a bouquet of things that can be done, but it has to be done within the confines of the clinical context where evidence-based surveillance is being carried out on that patient as they're moving ahead in their conception journey. This is what I have to say about that.
Okay, thank you so much, sir. I hope that helps the person that asked the question. Someone was asking, what of a husband who doesn't want to hear anything about IVF? What can I do, ma? I think that's directed to a ma. Then, how much should be expected for IVF? And for those that are not financially capable but want to undergo the process, what's the way out? The same person also asked, for couples above 40 that can't access IVF financially, what's advisable for them? So I think before you answer, let me just do the question in 2, 3. For someone advanced in age, so they are above 40, they can't access IVF financially. What is advisable for them? 1. Number 2, husband isn't interested in IVF. What can be done? And number 3, what is like the budget range for IVF?
Okay, I'll start first of all with the uncooperative spouse. Quite a lot of times when we're engaging a couple to prepare for treatment, like I mentioned during the speak, the psychology of shame has to be borne in mind. Yes, this question speaks to or is requesting information about an uncooperative husband, but it could be the other way sometimes. When I say uncooperation, not necessarily in saying she doesn't want to hear about it or he doesn't want to hear about it. It's more like they are exasperated because of, the years of being burdened with the issue, possibly previous failed treatment, possibly previous wrong treatment, So there's a lot of psychological pressure sometimes causing this. So what my advice to the clinicians who are caregivers, you need to really engage the couple directly. The IVF journey is not something that can be carried out by one party. It's be a couple, usually. It's fraught with a lot of 0.5% increases in chance. So I think it will largely do with counseling to try and elicit what is causing the lack of cooperation from either spouse. Because objective management requires that cooperation. You need the husband's sperm, for example, for whatever we intend to do eventually. And if he's not cooperative from the beginning, it will cast a shadow on the potential for that process to be successful. So counseling, trying to engage couples, right, and individuals from the outset, trying to establish trust for the couples, both of them, trying to identify the pressures within the relationship, probably as a result of the difficulty they've suffered, or probably as a result of beliefs that they are engaging in probably explaining why the process has not been suffered, possibly as a result of maybe previous infidelity. Now, every marriage has its issues, so one degree that fertility counseling places a whole lot of emphasis on is this, trying to make sure both parties in the couple are committed to the process of trying to achieve a pregnancy. Now, I'll move on to the financial aspect of fertility management. Yes, IVF fertility treatment is notoriously expensive or perceived to be expensive. But I need to draw some insight into what causes it to be expensive. What causes it to be expensive? And what is the relative cost of the processes compared to being successful with conception. The IVF process is a very technology-driven process. It also relies on quite advanced physiological science to prosecute. The simple objective is to be able to retrieve an egg from inside a woman. Not just an egg, a mature egg, not just a mature egg, a functional egg capable of being fertilized by the husband's sperm. The process is also supposed to keep this fertilized egg alive outside the body so that it thrives. The process is also supposed to give us the opportunity to transfer this fertilized egg back into the womb at a point where the womb is maximally receptive to it. It takes quite a bit to be able to do this successfully, realistically. And because of that large technology requirement, most of that technology is not sourced here. Most of it is imported in terms of the machines, the incubators, surgical processes, the scans. The medications also are imported. And sadly, this puts that financial burden on the clinicians trying to operate an evidence-based top-line service. At its best, conception in the natural domain, for successful implantation in a couple that everything is normal, implantation is 23, 24%. When we do IVF or ICS, we increase it to about 40, 45%, depending on couples. A little bit high sometimes lower. This is significant, but it has to be done right. It has to be done right, or it shouldn't be bothered to be done at all. I'm not saying that clinics cut corners or anything like that. I'm just saying that conscientiousness on the part of the caregivers to make sure each aspect of this process is properly offered to the couple so that they can maximize that chance comes at a cost. And it is expensive, I have to confess. And that's why we have ministries like the Quiver Ministry. A whole lot of philanthropic organizations are available that these couples can access to assist them. Quite a number of clinics offer subsidized services for patients who are having difficulty accessing finance to pay for treatment. Quite a number of clinics offer realistic discounts. I'm not talking about promos or anything like that. Realistic discounts to assist couples who are challenged financially. So I will suggest, I know it's tough. I know the economic climate is also challenging, but we just have to try and assess, groups who can offer financial assistance. Thank you. Mr. Right,
thank you so much, sir.